Hi, good afternoon. Again, this is Lynn Shull with the Association of State and Territorial Health Officials, and this is the Healthy Aging Oral Health Among Older Adults webinar. So thank you all for joining this afternoon. And we have a great panel of presenters, so we are going to go ahead and get started as close to the hour as possible. And just as a reminder, right now everybody is on mute, so if you have a question, please feel free to type it into the chat box as it comes to you, and we can address it during the Q&A. Or if you want to wait until the Q&A, you can press *7 to unmute your line. And following the webinar, we will send everyone a link to the recording of today's webinar as well as the PowerPoint presentation slides. And as I said, we have a great group of presenters with us here this afternoon, and we will be going in this order. First up, we'll have Kimberly Yineman with the Association of State and Territorial Dental Directors, who is their president. And we'll also have Kathy Phipps, ASTDD's Data and Surveillance Coordinator, Catherine Wino with the Division of Oral Health at CDC, then Jewel Mullen, the Association of State and Territorial Health Officials President, as well as the Connecticut Health Department State Health Official. And her colleague will be joining as well, Linda Ferraro, the Director of the Office of Oral Health, also at the Connecticut Health Department. And then we will end with a few minutes for question and answer and discussion. And of course, like I said, if anything comes up as the presenters are talking, please don't hesitate to ask it through the chat box. And we will go ahead and get started with Kathy Yineman. And just a quick reminder to press *7 to unmute your line. Kimberly, if that might be.
Thanks, Lynn. Can you hear me now?
Perfect. Yep. Perfect. Thanks.
Good afternoon, everyone. Today I'm going to present on the general importance of oral health and the older adult population. Oral health is an important and often overlooked component of an older adult's general health and well-being. The Surgeon General Report on Oral Health in 2000 emphasized that oral health is integral to general health. This report provides important reminders that oral health means more than healthy teeth and that you cannot be healthy without oral health. Oral health problems can cause pain and suffering, as well as difficulty in speaking, chewing, and swallowing, and can affect social and emotional well-being. Dental-related emergency dental visits have been increasing in the United States. One study reported that ED visits for non-traumatic dental conditions accounted for 1.4% of all ED visits in 2007. From 1997 through 2007, there was a 4% annual increase in non-traumatic ED dental visits. Oral health and systemic health are tightly interconnected. Poor oral health is associated with an increased incidence of pneumonia. Dry mouth caused by many medications increases the risk of dental decay. Diabetic glucose control is a challenge in the presence of periodontal disease, and periodontal disease is more pronounced in diabetic patients, especially those with poor glycemic control. Poor oral health can affect diet choices and is a common cause of weight loss and failure to thrive. Oral health problems can hinder a person's ability to be free of pain and discomfort, to maintain a satisfying and nutritious diet, and to enjoy interpersonal relationships and have a positive self-image. Oral pain is a sign of an advanced problem in a tooth or gum tissue. Although the pain may dissipate with time, professional attention is still needed. Oral health problems, either from missing teeth, ill-fitting dentures, cavities, gum disease, or infection, can cause difficulty eating and force people to adjust the quality, consistency, and balance of their diet. Tooth loss can have obvious negative aesthetic and functional consequences. Dentures can help restore their quality of life, although sometimes can be difficult to get used to. Because chronic diseases are so prevalent among older adults, many take multiple prescriptions and have over-the-counter medications. It is not uncommon to have side effects that are detrimental to their oral health. For example, antihistamines, diuretics, antipsychotics, and antidepressants can reduce salivary flow, which can result in dry mouth, which is a risk factor for tooth decay. Dental decay represents a physiological burden, especially for those whose systems are already compromised by diseases and aging. Decay is one of the main causes of tooth loss. Another is periodontal disease, an infection of the supporting structures of the teeth. According to recent national surveys, more than 70% of older adults in the United States have periodontitis. Preventing and/or treating periodontal disease is particularly relevant because recent studies have shown a possible association with diabetes and cardiovascular disease. Oral cancers include lip, oral cavity, and pharynx cancer. Adults 65 or older are 7 times more likely to be diagnosed than persons under 65. More older adults die from oral cancer than skin cancer. One of the overarching goals of Healthy People 2020 is to achieve health equity, eliminate disparities, and improve health regardless of socioeconomic status and ethnicity. Oral health within the older adult population falls short in this regard. Despite major improvements for the population as a whole, oral health disparities exist in many racial and ethnic groups by social economic status, gender, age, and geographic location. The economic factors that often relate to poor oral health include access to health services and an individual's ability to get and keep insurance. Only 22% of older adults are covered by dental insurance. Most of the dental expenses are paid out of pocket, and currently Medicare does not cover dental services. Unfortunately, financing dental care for older adults is difficult. Consequently, dental care is unreachable for many that are living on a fixed income. Noting the lack of access to oral health contributes to oral health disparities, the Institute of Medicine Committee developed a vision to improve oral health care for vulnerable and underserved populations and recommends strategies to achieve the vision. The committee envisioned an evidence-based oral health system that will eliminate barriers and contribute to oral health disparities, prioritize disease prevention and oral health promotion, provide oral health services in a variety of settings, rely on a diverse and expanded array of providers who are competent, compensated, and authorized, include collaborative and multidisciplinary teams working across the healthcare system. The committee established 2 principles to guide deliberations. 1, oral health promotion and disease prevention are essential to any strategies aimed at improving access to care. And 2, to foster continuous improvement and innovation. So thank you, and now we will hear from Kathy Phipps.
So first thing I'm going to ask is whether or not I'm unmuted. I'm going to make the assumption that I am at this particular point in time.
Yes,
well,
I can hear you.
Good. My name is Kathy Phipps. I am the Data and Surveillance Coordinator for the Association of State and Territorial Dental Directors, and I've been asked to specifically talk about the oral health of older adults and some of the data sources and the need for state epidemiology capacity. But first I want to mention just briefly about why this issue is so important. Our population is aging, and as one of the baby boomers, I am going to be one of the group of individuals that is driving the population so that there's a higher percentage of adults in the U.S. that are over the age of 65. And we have an increasing number of individuals that are actually reaching the age of 100. This is a photo of Thelma Scrimshire, who was in 2011 was crowned Miss Alabama Nursing Home. Unfortunately, Thelma passed away in March of this year at 104 years of age. Well, as the population is increasing in age, something else is happening concurrently, and that's a decline in total tooth loss. 1957-58, approximately 61% of the adult population aged 65 years and older were edentulous. They had no natural teeth. National survey conducted in 1985 and 86 found that 41% had no natural teeth. And the Behavioral Risk Factor Surveillance System from 2012 found that only 16% of the population over the age of 65 had no natural teeth. So a substantial decline in the prevalence of edentulism in the U.S. population. And so because of that, people are living longer with teeth. The unfortunate thing is that having teeth doesn't always mean having healthy teeth. And this is a photo that was taken in a nursing facility showing that this particular individual actually has decay on every single tooth, and the majority of the teeth now are just actually root fragments at this point in time. Well, even though people are retaining their teeth longer, there is still a problem with edentulism in the United States. Many people don't have dentures, and then if they actually do have dentures, many of them have dentures that are ill-fitting. Well, when we talk about data sources for adult oral health, there are a few data sources that are available at both the national and the state level. When we talk about oral health data, we actually tend to categorize data into 5 different categories: access to dental care, the risk factors and risk determinants for oral health, different types of intervention strategies that are available at the community and individual level. We have workforce, infrastructure, and policy data. In addition to that, we actually have oral health outcome data. Now, we need to have data from all of these categories to truly have a good idea as to what is happening as far as oral health is concerned. So let's quickly look at what all of the oral health data sources are. At the national level, when it comes to access to care, we have the Behavioral Risk Factor Surveillance System, or BRFSS. We have the National Health and Nutrition Examination Survey. We have the Medical Expenditure Panel Survey, and we have HRSA's Uniform Data System. So those are sources of data that's available that can give us information on utilization of dental care. For risk factors and risk determinants, again, we have BRFSS, we have NHANES, but we also have data available through the U.S. Census that can give us community information not only on the percentage of the population that's over 65, over 85, but also looking at poverty and education, English as a second language. In terms of intervention strategies, we have the Water Fluoridation Reporting System. For workforce and infrastructure, we have ASTDD's state synopses of dental public health programs. And for oral health outcomes, again, we have BRFSS, NHANES, and we also have cancer registries. At the state data level, for access to care, we have BRFSS. We also have the Uniform Data System. For risk factors and risk determinants, the same as the national BRFSS, the U.S. Census. But we also have data that may be available from each individual state's Office of Aging. And that Office of Aging, the name will differ from state to state. Intervention strategies, again, WAFERS, the state synopses of dental public health programs, and workforce and infrastructure, also the state synopses. For oral health outcomes, we have BRFSS, the cancer registries, and for those states that have done oral health surveys, we have state survey data specifically focusing in on vulnerable older adults. So the resources that are available, you can go to the ASTDD website, and I have the link on here, to a document that we have, which is the Data Surveillance Template. And that particular document lists all of the data resources that are available for different age populations. It has the link to that particular resource and then some information about each one of those resources. In addition to that, the Council of State and Territorial Epidemiologists published a white paper on state-based oral health surveillance systems, which gives detailed information on all of the different data sources that are available, how to actually set up a state-based oral health surveillance system, and what they recommend as a minimal data set for that state-based oral health surveillance system. And I have the links to those particular documents. It's both on the CSTE website and on the ASTDD website. So this is the ASTDD state data template, showing you just briefly how the template is set up. It gives you a topic, a work group, a descriptor of the indicator. It tells you whether or not that indicator is in the National Oral Health Surveillance System, whether or not it's related to Healthy People 2020, what the data source is, and then any related data comments that may be applicable for that particular data source. So that's a very good resource for everybody out there. So let's specifically talk about what the different data sources are and what the questions are, the information that's available from each one of those data sources. From BRFSS, we have time since the last dental visit in terms of access to care. The Uniform Data System has the number of patients that are served by an FQHC with a dental visit. It also includes the total number of patients so that you can calculate the percent of FQHC patients that had a dental visit. But another interesting thing in that is the percent of all patients served by an FQHC that are 65 years of age and older. And if you look at that, you will see that the FQHCs are actually underutilized by older patients. So it's something that we may be able to work with. Many of our older patients may not realize that dental services are available from FQHCs because they're not using them as often for medical care. For risk determinants and risk factors, from BRFSS, we have diabetes, tobacco use, alcohol use, poverty, education, employment, race, ethnicity, and an information on disability. From the U.S. Census, poverty, education, race, ethnicity. From your state office of aging, you may be able to obtain the number of long-term care facility residents in your state. And then also of interest may be the number or percent of bed days that are paid for by Medicare or Medicaid. And that will help you identify those facilities with a high percentage of the population is actually being served by Medicaid. In terms of intervention strategies, the Water Fluoridation Reporting System provides information on populations served by community water fluoridation. And then in addition to that, the ASTDD state synopses has information on whether or not a state has other intervention strategies specifically targeting older adults. That information is available on the ASTDD website, and then soon will also be on the CDC State Synopses website, which at this particular point in time is being restructured, so is not currently available. In terms of workforce, infrastructure, and policy, the State Synopses has information on number of dentists and hygienists in each state, the number of community clinics that provides dental services on a sliding scale. It also provides information on whether or not a state has infrastructure or policies specifically targeting both older adults age 65 and over, developmentally disabled adults, and then also nursing facility residents. So that's another source of information. In terms of oral health outcomes, the Behavioral Risk Factors Surveillance System has information on tooth loss. Cancer registries have information on oral and pharyngeal cancer morbidity and mortality. And then if your state has an oral health survey of vulnerable older adults, it's information on residents of long-term care facilities and or individuals that attend congregate meal sites. So I want to give you a quick example from the Behavioral Risk Factors Surveillance System, and this actually happens to be from Washington State. I downloaded the BRFSS data for Washington State, looked at oral health data from BRFSS in combination with some of the risk factors and risk determinants that are available through BRFSS. And you can see here that if you actually plot whether or not an adult 18 years and older has lost a permanent tooth, so one or more permanent tooth, and you plot that by what their self-reported general oral health status is, you can see that those individuals that report excellent general health, 25% have lost one or more tooth. And if you look at those individuals that show that they have poor oral or poor general health, 70% of those individuals have actually lost an adult tooth. So although many states do not use their oral health data in BRFSS and look at it by a variety of different risk factors and risk determinants in BRFSS, if you do look at this information, you can see that there's a relationship between oral health status and a variety of different indicators that are available through BRFSS. One other example is showing whether or not an adult 18 years and older has had a dental visit in the last year by their employment status. So if they are employed by wages, 71% had had a dental visit. And at the far right, if they had been out of work for more than 1 year, only 47% of those individuals had had a dental visit. So a direct relationship between employment status and access to dental care. So let's look at specifically the oral health of vulnerable older adults. To help states obtain information on the oral health status of vulnerable oral adults, ASTDD developed the basic screening survey, and it collects information or provides a protocol for states to collect information on individuals that are in long-term care facilities or attend congregate meal sites. State must collect the data from a representative sample, and we actually have states, a variety of states that have either already collected or in the process of collecting data on either one or both of these population groups. If we look at those states that have already collected the information, we have a little bit of information on the oral health status of skilled nursing facility residents. 1 out of 3 residents have no teeth. And depending upon which state they're in, as 13 to 45% of those individuals with no teeth are missing either one or both of their dentures. So in one particular state, 45% of the nursing home population had no teeth and were missing one or both of their dentures. For those skilled nursing facility residents with teeth, about half have untreated decay. Well, to look at this information and to be able to take the data that's available and advocate with that data, you need to have adequate epidemiology capacity. And for those of you out there that are epidemiologists, as I am, and everybody wants to know what an epidemiologist is, I came across this graphic online, and I thought it was actually a very good graphic that you may want to look at some point in time. So let's look at what the epidemiology capacity is in terms of oral health. This is the information that's from the State or Council of State and Territorial Epidemiologist Capacity Report. I have the link to this individual capacity report online. So they have a capacity report for environmental health, for maternal and child health, chronic disease, oral health, and then an overall capacity, epidemiology capacity assessment for the states. If you haven't seen this information, I would highly recommend that you take a look at these capacity assessment reports. So in terms of oral health capacity in relationship to epidemiology capacity for chronic disease and maternal and child health, 66% of states report that they have at least substantial epidemiology capacity for chronic disease. That means that they can actually do 50% of the work associated with epidemiology capacity with the state. For maternal and child health, 73% of states report they have at least substantial capacity. But for oral health, only 26% have appropriate capacity. So substantially less likely to have adequate capacity. 59% of the states have no or only minimal oral health epidemiology and surveillance capacity. So the majority of states have no capacity. So overall, for all states to reach almost full oral health epidemiology and surveillance capacity, states need 33 additional oral health epidemiologists. So there is definitely a shortage of oral health epidemiologists. This report has several conclusions. The first is the status of state oral health epidemiology and surveillance capacity is abysmal, with most jurisdictions having minimal to no capacity. And to improve capacity, funds must become available for additional positions, and efforts must be made to ensure that each state has a designated lead oral health epidemiologist. So because we are running short on time, I'm going to skip over the recommendations and actually shift the presentation to Catherine Wino. Dr. Wino, the table is yours.
Thank you, Kathy. I'm going to assume everyone can hear me. Now for something completely different. I'm happy to be here today to talk to you a little bit about our new Public Health Service recommendation. I was asked to present information about the release that we did in April. It's been a big year for the CDC. We did finally release the Public Health Service recommendation as it relates to water fluoridation, something that had been in the process since 2010. I'm thrilled to report that it is now available for all of you public health professionals as well as water operators to use. But before I start, I want to acknowledge Barbara Gooch for the slides that she provided for this presentation. She's our Associate Director for Science and one of the primary authors of the PHS recommendation, so I want to acknowledge her work on this. First, to provide a few definitions. Water fluoridation is the adjustment of fluoride in drinking water to a level that is optimal for the reduction of dental decay. Most of you know that fluoride is the ionic form of the element fluorine, and that element is extremely common in the Earth's crust. What happens is as water passes over rock formations, it absorbs fluoride ions, so almost every body of water on Earth contains some sort of fluoride. For example, water in the ocean contains fluoride at levels that are at or above most levels that are used for community water fluoridation. Rivers, lakes, and streams contain less fluoride, so water systems who are using those types of water sources add fluoride to their water systems to make sure that those that use that or drink that water are getting optimal fluoride that helps their oral health. So how much fluoride should be added to water supplies in order to ensure that it has an impact on people's oral health? That is the question that HHS answers in the new Public Health Service recommendation. The original recommendation was established in 1962 and was a range from 0.7 to 1.2 milligrams per liter. The reason for the range was that the lower concentrations were recommended for warmer geographical areas and the higher concentrations for cooler areas. The range was based on studies that were done in the 50s that found that children drink more tap water on warm days. We've got more recent evidence that shows that outdoor temperature is not really an important driver in the amount of water intake among children. So in 2010, we convened an interagency panel of federal scientists to review all relevant evidence that we needed in order to update the 1962 recommendation. In January 2011, the proposed recommendation was published in the Federal Register, and the recommendation was that there be a single target of 0.7 milligrams per liter, which was the lowest end of the range established in 1962. The intent of this new standard was to balance what we know are the health effects of preventing tooth decay in children and adults while reducing the amount of fluoride exposure in children. We did propose, as I said, we published these in the Federal Register, and we received thousands of comments, which CDC reviewed, categorized, and responded to, and these responses are included in the final recommendation that was published in 2015. Even though these recommendations weren't finalized until this year, Since 2010, many water systems just went ahead and implemented the new recommendation. For example, by the summer of 2011, just 6 months after the proposed recommendation was announced, almost 68% of people served by community water systems were drinking fluorides with fluoride concentration of 0.7 milligrams per liter. In April, we finally released the Public Health Service recommendation at the National Oral Health Conference. It was also published in the Federal Register and in Public Health Reports. And for all of you that are interested in this topic, I recommend that you go to the Public Health Reports link on this slide and read all of the materials associated with the recommendation. That link contains the full text of the recommendation along with the responses to the comments that we got, which will answer many of the common questions that people have about water fluoridation. It also contains a statement of support from our Surgeon General, Murthy. I think it is important to remind everybody that there isn't a federal requirement to fluoridate, and the Public Health Service recommendation is not a legally enforceable mandate. States and local communities decide for themselves whether to fluoridate or not, and in doing so, they weigh the very clear oral health benefits and the science among other community concerns. These decisions are always made on a local level, sometimes it is by elected officials, and sometimes by public vote. Our role at CDC is to monitor the public health benefits and risks of water fluoridation. Now that the recommendation is out, we're going to continue to do that work by monitoring the systemic reviews of effectiveness and safety. We look at published reports and peer-reviewed literature, and we also sponsor a great deal of surveillance data about fluoridation and fluorosis that I'm going to talk about in a minute. The numbers of people in the United States benefiting from community water fluoridation continue to increase. This graph shows the increases since 2000 in the overall U.S. population, which is shown in light blue here, and then the population served by community water systems, shown in purple, and then the bottom bar is gray as the number of people that are on community water systems that are receiving fluoridated water. You can see that the number of people that are receiving fluoridation is increasing faster than the general population is. Just some fun facts for you. By 2012, more than 210 people in the U.S. were receiving fluoridated water. Since 2000, more than 48 million people in the U.S. have received fluoridated water for the first time. More than 6 million people were added between 2010 and 2012 just alone. And by 2012, almost 75% of the U.S. population served by community water systems received fluoridated water. These are great numbers for those of us that care about oral health, but just to keep this in perspective, we've still got some work to do in order to meet the Healthy People 2020 objective. That objective, which most of us in public health work with, is to achieve 79.6% of the population on community water systems to be receiving optimally fluoridated water by 2020. Community water fluoridation has been a major factor responsible for the reduction of dental caries or tooth decay in the United States during the second half of the 20th century. This graph shows declines in the prevalence and severity of dental caries in permanent teeth of adolescents across 3 decades from the early 70s to 2004. The percentage of adolescents with at least one permanent tooth affected by tooth decay has decreased from 90% to 60%, and the average number of decayed, missing, or filled teeth has decreased from 6.2 to 2.6. While these reductions in dental caries are impressive, dental caries in the U.S. remains a highly prevalent condition, as Kathy talked about in her last presentation. 1 in 4 children that are from low-income families have untreated tooth decay. And as we all know, untreated tooth decay can cause pain, school absences, absences at work, decreased productivity, and poor appearance. And we still continue to struggle with large proportions of adults and children having tooth decay. For 70 years, people in the United States have had better oral health because of fluoridated drinking water. The effectiveness of this public health intervention is well documented. In 2013, the Non-Federal Community Preventative Task Force has updated their review of the effectiveness of water fluoridation that was originally released in 2001. This 2013 review reaffirmed their earlier finding that there is strong evidence that fluoridation is effective in reducing tooth decay among children and adolescents, as well as adults. Susan Griffin, an economist at the CDC, also published a systemic review of the effectiveness of community water fluoridation in adults. It also contained an analysis that was limited to 5 cross-sectional studies published after 1979, when other sources of fluoride, including toothpaste and mouth rinses, were widely available. Of these 5 studies, they were also conducted among adults with lifetime residency in either fluoridated or non-fluoridated communities. So the ultimate statistic here is that tooth decay was reduced by 27% for those residing in fluoridated communities. Since the publication of the Griffin Review in 2007, another analysis of the data looked at exposure to community water fluoridation among adolescents and adults in Australia. Overall, they found that greater lifetime exposure to community water fluoridation was associated with lower caries experience among adults. They also found that reductions in caries were at least as large for adults born before the implementation of water fluoridation as in compared to after the implementation of water fluoridation. That indicates that fluoridation can benefit oral health throughout the lifespan. Water fluoridation is extremely cost-effective for communities that are concerned about their population's oral health. 2 systemic reviews found that fluoridation was cost-saving in all studies. Several states have done analysis looking at Medicaid costs for the treatment of tooth decay in fluoridated and non-fluoridated communities. A couple of examples of this are Louisiana, where their mean treatment dental costs were $67 lower among preschoolers living in fluoridated versus non-fluoridated parishes. And a similar analysis in New York was done comparing costs of caries-related procedures among children and adolescents living in fluoridated and non-fluoridated counties, and the difference was about $24. Fluoridation is also known to be safe. The only known unwanted health effect of fluoridated water is dental fluorosis. Dental fluorosis is a condition that impacts the opacity of enamel of teeth in its most common form. It occurs only when teeth are forming and is based on the amount of fluoride that is received during that time. So only children aged 8 and younger can develop dental fluorosis. Most fluorosis in the United States is in its very mild or mild form, which is mainly a cosmetic concern. And in most cases, the only person that can detect it are dental professionals that are working with strong lights and mouth mirrors. There is a clear dose relationship between fluoride concentration and fluorosis, and there is no evidence that community water fluoridation, the concentrations associated with fluoride in community water fluoridations, cause severe dental fluorosis. Lifetime exposure to very high concentrations of fluoride, far in excess of the recommended levels for fluoridation, have been associated with bone fractures and skeletal fluorosis. This is very rare in the United States and is generally associated with nationally occurring fluoride concentrations. Concentrations, for example, at 4 milligrams per liter, which is over 4 times the recommended amount. Fluoridation at optimal levels are not associated with skeletal fluorosis or bone fractures. Again, we have another systemic review by the National Research Council that also looked at the unwanted health effects of water fluoridation. They also agreed, even though their review was done at water concentrations even higher than what we're recommending at 2 to 4 milligrams per liter. And even at these higher concentrations, the review concluded that there was the only increased risk in water fluoridation was dental fluorosis, and the prevalence of severe dental fluorosis was near zero at concentrations of less than 2 milligrams per liter. Those of us that work in fluoridation are also dealing with many concerns and comments. We have a lot of claims on the internet and in the media about the impact of fluoride. A lot of what's been talked about lately is the impact of fluoride on the brain, specifically IQ scores in children. These articles use as the basis for their discussion a lot of articles that were taking place in China. This slide shows a lot of the discussion of these slides, and in the interest of time, I will not go through them. But suffice it to say that most of these studies were did not meet scientific rigor, and there were a lot of questions that were generated by these particular studies. In contrast, there is a 2014 study that was done in New Zealand that did not show any type of association between fluoride exposure in childhood and IQ scores. Opponents of fluoridation also connect water fluoridation to a host of other conditions, including cancer, hypothyroidism, ADHD. And again, I just want to stress that the only unwanted health effect that is supported by peer-reviewed credible science is dental fluorosis. We also deal with a lot of discussion about the ethics of water fluoridation, it being mass medication of the population. Again, just stressing that water fluoridation is a local issue, and it is up to individual communities to discuss whether this is the best thing to do for themselves. Court reviews have consistently viewed community water fluoridation as a proper means to improve public health. We at CDC will continue to work on monitoring the benefits and risks of water fluoridation. We have invested a great deal of time and effort into data sets and surveillance on this topic, and you should be looking towards, we will be releasing new information in the near future. Again, water fluoridation has consistently been supported by public opinion, although the media and the internet also host a range of opinions. For the most part, most people are aware that water fluoridation is a safe and effective way to protect their children's teeth. The CDC has numerous resources that you can use to support your water fluoridation advocacy efforts if you choose. In the last year, we have released a number of posters and public information that are available for download on our website. We have posters that we have produced, a couple of examples here, and we also have a web badge that you can use on your internet materials. In closing, this is a slide that indicates all of the professional organizations that support water fluoridation, and I am going to turn the comments over to the next presenter. Thank you very much.
Thank you. This is Jewel Mullen, and I hope that I'm audible.
You are. Thank you.
All right. I'd like to thank everyone who helped organize this call, this webinar, for giving me a chance to participate and to start out by acknowledging a year's worth of effort on the part of Chris Wood to make sure that the behind-the-scenes work that we have been doing between ASTHO and ASTDD to bring a broader conversation around healthy aging and the oral health of older adults to all of you. It's my pleasure to be able to do that. And I'm also very happy to share my time with Linda Ferraro, who is the Connecticut State Dental Director. As the commissioner here, I feel really fortunate, having listened to the previous presentations, and to realize that I've been able to work in two different state health agencies where there have been funded oral health programs. I realize that they are a precious resource, and I know the degree to which, when I got to Connecticut, it was important to make sure the governor understood that as we were going through budget cuts, and we were clinging to dollars to make sure we didn't lose our oral health program. In talking to you about my presidential challenge on healthy aging, my call to action to my counterpart state health officials to ensure that older adults can live and age well, especially in the communities where they desire to be. I want to mention that I'm not a dentist. I'm not an oral health professional. I'm an internal medicine physician. But as a doctor, I know the numbers of patients who have come to me over the years because I was the only source of medical care that they could get for a dental problem. And while that was something that was apparent for adolescents and young adults, that extended far into the reaches of people's later years as well. and it was never easy to just figure out where many people could go unless they were already diabetic or had some other comorbidity that an insurer decided earned them a little bit of dental care. So in talking about healthy aging and issuing a call to action to my state health officials, I quickly learned that healthy aging meant different things to different people. And over the past year, I've shown the slide of the blind man and the elephant to remind us of that, primarily because as soon as I start talking about older people, I would get reactions about nursing home quality, excess medical expenditures at the end of life, falls, caregiver burden, Alzheimer's disease, or multiple chronic conditions. And even when people talked about multiple chronic conditions or chronic disease, rarely did they mention oral health. And we've been deliberate here, and I know Connecticut's not unique in this, as we look at our chronic disease programs to ensure that oral health is part of them and not an accessory. So in talking then about oral health, I've reminded people that we're talking about the highest level or optimal level of physical, emotional, and social well-being that an older adult can achieve. Not just longevity and not just increasing life expectancy, but thinking about how to ensure that in a society in which people continue to live longer, they can live as healthfully as possible. And I propose to you that as we think about healthy life expectancy and the understanding of how it varies geographically in our country, in the same way that I tell people, think about the CDC's maps on obesity or other conditions. We see where the variations are in healthy life expectancy. It would be interesting for me to see this mapped out for healthy teeth life expectancy in the same way. So I leave that to the epidemiologists in the group to consider that. But certainly, as a physician and as a public health professional, just referencing everything that's been presented today, I can also say that we'd be ignoring an important component of health if we did not acknowledge oral health along the way. So in my call to action to my counterpart commissioners, what I asked them to do was not feel as if they needed to become aging experts, but even better collaborators as public health practitioners. And many of us know that when we lead efforts, sometimes people can think, what's public health have to do with that? What does oral health have to do with that? But in our holistic approach to our work, we often identify that we are trying to advance strategies to achieve outcomes that are shared by other partners. So I based my presidential challenge on that mindset with the thought that state health officials could use a national prevention strategy framework to advance healthy aging, focusing on the 4 strategic directions of the National Prevention Strategy: healthy and safe community environments, clinical and community preventive services, empowered people, and elimination of health disparities. And I submit to you that every one of those strategic directions has been advanced in the presentations that we've already heard today. And among the 7 priority areas, including tobacco-free living, preventing drug alcohol abuse, healthy eating, and you see the others on the slide, there's a lot in there that also touches oral health, even without it specifically being spelled out as oral health or chronic disease prevention. So given that and the National Prevention Strategy approach, I can tell you that what we have been able to do over the past year is identify where a number of states have already undertaken a variety of initiatives to improve oral health care. And in just a few minutes, Linda's going to tell you about some of what we've been doing in Connecticut. At the same time that has been occurring, I've also been aware of the ongoing efforts nationally to get Medicare coverage for oral health care for older adults, which I think is especially important. Thus far, 35 state health officials have signed on for their jurisdictions to advance healthy aging. I imagine there are some of you on the call who are already engaged in some of that work in your states. I also pledge to you that as I continue to talk to my counterpart health officials, I remind them to really take deeper looks into their chronic disease programs, oral health programs, and where the opportunities are, not so that you can feel that they're going to be hands-on, but so that you can feel that they can support you in whatever way they can. And for all of us to consider, as we're thinking across the country, how we advance improved oral health for older adults, a couple of things to keep in mind. We've already seen a suggestion that part of what we need to do with our data analysis is understand the workforce. Well, understanding the workforce with the recognition that the number of adults over the age of 65 is projected to double sometime between now and between 2040 and 2050 makes us project our workforce needs to be most likely even greater than we think they are right now. And then given that the majority of older adults, more than 90%, would prefer to stay in their homes, in their communities, although we understand that that's not going to be an option for some and that there will still be those in long-term care facilities, that at least bifurcated approach to thinking about oral health care for community-dwelling elders and those in long-term care facilities is very important, and we certainly need to continue to advance strategies for both. When I worked at the Massachusetts Department of Public Health, and we released a report on the oral health status of older adults, I remember being interviewed after the report was released, and Lynn Bethel was the oral health director at the time. But I remember in an interview saying that having healthy teeth is actually a social justice issue. It's not just a cosmetic issue, and that continues to be the case. And from the perspective of an ASTHO president who's advancing healthy aging, to highlight the importance of oral health care is something that I feel even more strongly about, having talked to dentists who have literally asked me, why do that if people aren't going to live that much longer anyway? So I take that again as a reminder that this is not just a health issue, but it's also an issue of justice and fairness as we think about equitable treatment for older adults and continue to value them as they are ongoing contributors to our society, who have active, vibrant lives, want to have fun, be as active as they can be, not just be in isolated communities with people their own age, but oftentimes in multi-generational settings where they can maintain physical activity and enjoy the outdoors, and where they continue to be connected to people who care for them and care about them. That's especially important to me, I think, and I'll end right there with, again, a thanks to all of you for the partnership and the ability to ensure that oral health care is incorporated into our healthy aging strategies. And now I'm happy to turn this over to Linda Ferraro.
Thank you, Dr. Mullen. We are very fortunate in Connecticut that we have a commissioner who's so committed to oral health and healthy aging, and I just want to say thank you for all that you do here in Connecticut and across the country, especially with your challenge. So oral health has been oral health for older adults has been a relevant issue in Connecticut for several years. In November 2006, the Connecticut Department of Public Health established a task force on oral health for older adults in response to concerns in the community regarding the availability and accessibility of oral health for older adults. The task force was charged with developing actionable strategies to improve the oral health of older adults in Connecticut and was comprised of representation from agencies and organizations invested in the overall health and well-being of the aging population in Connecticut. The members of this group met monthly over a one-year period and produced its recommendations in a 2008 report called Just the Facts. This report highlights 5 key focus areas to improve oral health for older adults in Connecticut, which are financing, advocacy, communication, training, and services. In 2009, the Connecticut Department of Public Health was the successful recipient of a National Association of Chronic Disease Directors Opportunity Grants for Healthy Aging. And that grant was to develop an action plan which would identify and prioritize activities to implement the recommendations in the Just the Facts report. The 3-year action plan detailed specific activities, responsible parties, and outcomes under each of the 5 key focus areas. While the task force report recognized that the prevalence and severity of oral diseases and conditions in older adults were a significant personal and public health concern, the extent of oral disease in older adults in Connecticut was poorly defined. The only indication of oral health status of older adults in Connecticut came from BRFSS, which Kathy discussed earlier. So in an effort to address this lack of data, the Office of Oral Health conducted its first basic screening survey of older adults in 2011 with funding provided by our second NACDD grant. This survey was a statewide oral health assessment of 2 population groups, the residents of long-term care facilities and adults attending federally subsidized congregate meal sites. The survey represents a segment of the state's older adult population and is not representative of all of Connecticut's older adults. However, it provides us a snapshot of the prevalence of oral disease and unmet needs of the older adults, which can be used as a benchmark for future assessments of this segment of the population. The results of this survey, which were published in 2013, demonstrated that many vulnerable older adults in Connecticut are not getting the dental care they need, and untreated dental care is a significant problem for vulnerable older adults, especially those living in long-term care facilities. Of those screened in long-term care facilities, 53% had untreated decay, and 42% were reported to have substantial oral debris at the time of the screening. These findings substantiated what we knew anecdotally and prompted the modification of Connecticut General Statutes in 2014 to now require mandatory oral health training in oral health and oral hygiene techniques for direct care nursing staff in all Connecticut long-term care facilities. This task force continued to meet on a regular basis and in 2014 joined forces with the Oral Health Strategic Research Alliance to become the Oral Health for Older Adults Consortium. The Oral Health Strategic Research Alliance was formed as a result of the first of 3 Connecticut-based oral health studies funded by the National Institute for Dental and Craniofacial Research. These studies joined the collaborative efforts of the University of Connecticut School of Dental Medicine, the Institute for Community Research, and the North Central Area Agency on Aging, with a focus on improving the oral health of older adults in low-income housing in central Connecticut. These studies, under the title Project Good Oral Health, have enabled the identification and development of oral health infrastructure and educational support, as well as conducting and evaluating a successful bilingual pilot intervention to improve oral health self-management in residents of one senior housing site, which has now been expanded to a 5-year study to conduct and evaluate outcomes of face-to-face oral hygiene education and oral health campaigns in 6 senior housing locations involving over 450 residents. Another project happening in Connecticut is Got Care, Geriatric Outreach and Training with CARE, which is an interprofessional collaborative practice project through the University of Connecticut School of Nursing, which is supported by a HRSA grant. The purpose of Got Care is to provide nursing leadership in the development and execution of an interprofessional team, increase workforce expertise in geriatrics by providing a learning experience for UConn students in the fields of nursing, physical therapy, social work, pharmacy, and dental medicine, as well as the Middlesex Hospital Family Medicine residents. In addition, they will be improving the care of Middlesex Hospital vulnerable older adults by conducting in-home comprehensive geriatric assessments that include an oral health assessment and link patients to needed services through care navigation. It has been highlighted that the interprofessional approach is the way that we need to approach dental issues. We recognize that and are very proud that our partners are working towards that. So these were just some examples of the accomplishments in Connecticut to improve the oral health of our aging population. The consortium continues to meet and is working on the development of our next action plan to further these efforts. Thank you.
That is fantastic. Thank you so much to Linda, Dr. Mullen, and all of our presenters today. And I know that we have reached 3:02 on the East Coast, so I don't want to, I want to be mindful of everyone's busy schedules and time constraints. But please, if there are any questions that you had that have percolated now or after the webinar, please don't hesitate to contact me. My email address is there on the slide, and I am happy to answer the question myself or delegate it to one of the experts who spoke today. So please don't hesitate to email me. And also, once you close out of the webinar box, you'll be directed to an evaluation of today's webinar. So please take a couple minutes to complete that. And you can also ask any questions for the presenters in there as well. So again, thank you so much to everybody who joined this afternoon, and a special thank you to our presenters as well. And I'll send an email to all of the registrants, including the attendees today, with the PowerPoint slides as well as the recording of today's webinar. So that'll be out later this week or early next week. But again, thank you all for joining, and have a wonderful afternoon.